Good morning, everybody. This is Mrs. Franson, and I'm recording chapters 15 and 26 because I think we'll have a limited amount of time in class. We'll probably spend our time in class just doing activities on that day, so you'll have your complete lectures available this way. Anxiety is the feeling of apprehension, uneasiness, dread, and it can be from a perceived threat or a real threat. You do have a fear component. You may be reacting to a specific danger, like coming upon a stranger or stepping on a snake. Anxiety is our friend and our enemy. Anxiety is there as part of our physiological makeup to help us to survive. Anxiety is very close to the flight or fight response that occurs in our mind. But unfortunately, abnormal levels of anxiety can be very hurtful to us both psychologically and physically. Unfortunately, an abnormal level of anxiety causes the same basic psychological responses as fear does. And so it can affect us very deeply on both an emotional level and on a physical level. On an emotional level, high levels of anxiety can erode feelings of self-esteem and self-worth. And on a physical level, anxiety is very exhausting. You can't stay in a heightened awareness state, a state of fight or flight for very long without becoming exhausted. I made this chart for you so you could see how levels of anxiety affect the patient's ability to think. In the mild form, this is our self-protective mechanism for our species. Our focus sharpens. We're looking at the environment. We're assessing the potential for danger. We're doing a very intense problem solving during mild anxiety. Unfortunately, if our anxiety level moves up to moderate, then it's hard for the patient to pay attention to what's going on. The sympathetic nervous system is in high gear, your fight or flight nervous system. And so even though they're trying to see the danger and assess the danger in their environment, it is an overwhelming event. If they move on to severe anxiety, then problem solving is not possible. And so that person's only goal is to reduce anxiety, and they may do it in a healthy or an unhealthy manner, but everything they do is to lower their level of anxiety because they're at a point where their level of anxiety is intolerable. If they move on, they can actually move to panic mode. This is a state of extreme anxiety, and what you may see in a panic mode patient is disturbed behavior. They're not going to be able to focus on anything, so it's going to be very hard for you to communicate with them. They may have disorganized or irrational reasoning, and they may lose complete touch with reality. So let's look at a situation that we might see. A parent is shopping with a 5-year-old child in a large, busy urban mall. The parent suddenly realizes that the child is missing. So if you're approaching this person, what level of anxiety do you think would result? Well, certainly their anxiety, I would think, would be on the upper end, that they would be panicking over where is their child and is their child safe. So if you're trying to deal with this person, what behaviors might the parent be exhibiting that would indicate their panic level anxiety? They might be running all over the mall. looking for their child in a state of panic. They might be pacing, they might be wringing their hands, they might be shouting, "Where's my child? Have you seen my child?" They might be screaming. They might not be able to listen to you when you try to talk to them and let them know you're there to help them find their child. People can even get to a state that they're physically uncoordinated. They might fall on the ground, and then they may do something very impulsive, like take a swing at you or at someone that they perceive to be threatening. Now, all of us have built-in defenses against anxiety because we want to protect ourselves from anything other than mild anxiety. So, let's talk for just a minute about defense mechanisms. Defense mechanisms are our automatic coping style that's built into our personality. Defense mechanisms are there to protect a person from anxiety. So anytime a person uses a defense mechanism, you know that they're already feeling a rising level of anxiety. Defense mechanisms also are there to maintain our self-image. We want to think of ourselves, let's just use honesty as an example. Suppose you're a person who does not want to be dishonest. You want to think of yourself as an honest, upright, outstanding person. So if you do something dishonest, you may say to yourself an excuse. You may use a defense mechanism to explain away behavior that's unacceptable to you based on your moral code. Like, for instance, well, he left the money there. He left the money at my house, so that's not really stealing. Or, I failed the test, but it's not my fault because my teacher's a sorry teacher. These are examples of defense mechanisms that we use to maintain our self-image because we want to see ourselves as having certain standards of behavior and certain abilities, and so we're going to cast responsibility onto other people. We may also have the need to block certain feelings, like suppose you are a Christian person and so you've learned throughout your childhood that you shouldn't hate people, but you have deep feelings of hatred in your heart for a certain person, so you may block those feelings with the use of a defense mechanism. Also, something terribly painful may have happened to you in the past. Maybe you have a client who has been sexually abused as a child, and so they block that. They block the memory of that, so that it doesn't threaten their perception of themselves. And also conflict situations that you have to resolve. And let's use abortion as an example of this. Maybe you are a person who's politically conservative, and so you feel abortion is wrong, but the only place you can get a job is at the abortion clinic. So how do you resolve that conflict? You may use defense mechanisms to resolve it. Don't forget that, as I said at the beginning of this slide, a defense mechanism can be, oh, maybe I didn't say this. Defense mechanisms, just like anxiety, can be your friend or they can be your enemy. They can be adaptive or they can be maladaptive. How do we use a defense mechanism in an adaptive manner? We may use it for a short term until we can get to the point that we can face the truth. If a defense mechanism is unhealthy or maladaptive, we may use it for years to avoid facing the truth. We may become rigid and unbending. We may repeat the same self-destructive behavior over and over and over because we're misusing a defense mechanism. So how do we decide if defense mechanisms in our patients are adaptive or maladaptive? We look at how often are they used, how intensely are they used, and how long do they last. Now, do people realize they're using defense mechanisms? I think the best answer to that question is sometimes they do and sometimes they don't. For many people, defense mechanisms are um, started on a subconscious level, and so they're unaware that they're using them to an excessive degree. We're going to also today talk about anxiety disorders, and this is a list of some of the anxiety disorders that we'll be covering in this lecture. Individuals with anxiety disorders are rigid, they're repetitive, they use ineffective behaviors to try to control their anxiety. These individuals experience a high degree of anxiety, so high that it interferes with personal, occupational, and social functioning. Okay, anxiety disorders include separation anxiety disorder and panic disorder. Separation anxiety is a part of infant development. It begins about the age of 8 months. It usually peaks at about 18 months, and then after that it slowly declines. How does it manifest in a child? It may manifest as fear, as headaches, GI symptoms. Now, when is it a problem? It's a problem when it's developmentally inappropriate. So if a 6-year-old or a 10-year-old is still unable to separate from a parent without laying on the ground and saying they're going to throw up, this is a problem. And so the issue is that a natural phase of childhood does not resolve at the appropriate time. Do we see separation anxiety disorders in adults? Yes, we do. They're more common in children, but we do see them in the adult patient. They usually manifest for the first time prior to the age of 18, and they will attach to other people as they get older in life. Like maybe they have an issue where they cannot be away from their spouse or one of their own children or something like that. And often it will exacerbate after a significant stressor. So maybe as a young child they had a parent that was ill or died, or they had a very significant stressor, and then that was when the disorder occurred for the first time, and it will manifest itself in adulthood. Now let's talk about panic disorder. During a panic attack, normal functioning has to be suspended. The patient may think that they're losing their mind, that they're having a heart attack. Their symptoms are not usually tied to stress. They just come right out of the blue, and that's a very important thing to remember about a panic attack, is that they cannot relate it to a specific stress. So the physical symptoms of panic attack include chest palpitations, chest pain, difficulty breathing. A lot of people feel that they're having a heart attack when they have this particular event happen in their life. And if you will look at table 15.3, and I'm looking at it too, to see if I need to tell you anything about it. Excuse me just 1 minute while I look it up. Okay, table 15.3 is good to look at because it gives you a great review of interventions that you could use to help a person who's having a panic attack. And we will do an activity in class on Monday to talk about how to intervene and help a person who's having a panic attack. Now let's talk about agoraphobia. Agoraphobia is excessive anxiety or fear about being in places or situations from which escape might be difficult or embarrassing. People who suffer from agoraphobia may not be able to leave their home. They may not be able to get in a car, get on a plane, ride a bus, or a train or anything. They may have fear about crossing a bridge or even riding in an elevator. So their life is all about avoidance behaviors. How can they avoid doing all these things? It takes over their life, and this disorder is very debilitating and life constricting. An example of a famous person who's had this problem was Paula Deen when she was young. Now, specific phobias are really very extensive. People have phobias about just about anything you can think of. Arachnophobia is the fear of spiders, and that's one of the more common ones. But people are afraid of heights, they're afraid of open spaces, they may be afraid of lightning, they may be afraid of blood. There's no telling. I mean, animals, strangers, fire, birds, snakes, you name it. Anything, just germs, anything you can think of, there's somebody out there that has a phobia about that. So you can read about the different kind of phobias on page 285 if you would like. When a person does have a specific phobia, the individual experiences an overwhelming, illogical, and crippling anxiety when faced with the object or situation. Social anxiety disorder is a disorder where they have severe anxiety or fear provoked by exposure to a social or performance situation that will be evaluated, that could potentially be evaluated negatively by others. A lot of famous people, believe it or not, that are performers, such as Barbra Streisand, suffer from this disorder. Now, a lot of people that have social anxiety disorder live very secluded, isolated, intensely private lives. They're not comfortable being around other people. You can imagine that this presents a tremendous difficulty for somebody who's trying to function in the real world and get a job and have a relationship with others and that kind of stuff. Okay, and generalized anxiety disorder is when a person has excessive worry that lasts for several months, and the worry is out of proportion to the true impact of events or situations. They have a lot of physical symptoms. They're very restless. They may be irritable. They may even have a lot of muscle tension. Now, these are people that are going to be quick to anger, quick to cry. They are immersed in their worry. And so you may know someone like this. Other anxiety disorders can be secondary to other types of problems. For example, you can have anxiety disorder secondary to substance abuse, and that's called substance-induced anxiety disorder. If you're taking certain types of drugs or substances and abusing these, you can develop this. You can also have anxiety secondary to certain medical conditions like hyperthyroidism, pulmonary embolus, and cardiac dysrhythmia. I know I've told you guys the story of a very large patient I had that I was taking care of after a C-section. The lady weighed between 300 and 400 pounds, and she just had a very painful abdominal surgery, but she experienced a pulmonary embolus, and she had tremendous panic because I was standing by her bedside talking to her when it happened, and she was out of that bed and trying to get in my arms before I even knew what happened. So they can definitely have a strong response when this event occurs. Now, people that suffer from substance-induced anxiety disorder, you may see them express the symptoms of anxiety, They may suffer panic attacks. They have a lot of obsessions and compulsions in their behavior. Now we're going to talk about obsessive-compulsive disorders because they fall under anxiety disorders. So let's just lay the stage by saying that what is an obsession? It's a thought, an impulse, or an image that they cannot stop engaging with. These thoughts, impulses, and images persist and reoccur. They cannot dismiss them from their mind. The obsession leads to the compulsion, and the compulsion is some type of ritualistic behavior that the patient performs to reduce their anxiety. They don't perform their compulsion because they want to. They can't stop themselves from doing it. Performing the compulsion temporarily reduces anxiety, but because the relief is only temporary, the compulsive act must be repeated again and again, and so the person is caught in a cycle. They're trapped between their obsessive thoughts and a drive to continuously perform their compulsive behavior. Most patients experience both the obsession and the compulsion as a pair. Pathologically, OCD or obsessive-compulsive disorder usually involves issues of sexuality, violence, contamination, illness, or death. The patient's embarrassed by the ritual, but they can't stop performing the ritual, and it interferes with their normal activities, their social activities, and their relationships with others. For example, the person needs to go to work, but they can't go to work because they have to keep going back to their home and checking all the doors or washing their hands or, whatever their ritual might be. Another obsessive-compulsive disorder is called trichotillomania, which is where a person cannot stop pulling their hair, and this is an example on the slide of that. There also is another disorder called dermatillomania, where the person picks at their skin. Why are they doing this? What is this behavior doing for them? It's lowering anxiety. That's why they are driven to do it. So let's talk about body dysmorphic disorder for just a minute. All of these disorders on this page have an obsessive-compulsive component and obsessive-compulsive characteristics. Body dysmorphic disorder refers to patients who are preoccupied with an imagined defective body part, and no amount of intervention by healthcare providers to convince them that whatever their perception is about their body isn't true does not help them. As a matter of fact, we think that 25% of people that seek cosmetic surgery suffer from body dysmorphic disorder, and they're willing to undergo surgery to correct something about their body that they don't like. Their characteristics include acting perfectionistic. They have a conviction that they're disfigured. They have overwhelming feelings of disgust, shame, and depression. And so this raises their anxiety level. So that's where the anxiety comes in. And it's very resistant to treatment. Generally, people who go into treatment for body dysmorphic disorder are not successful with their treatment. Hoarding also falls under obsessive-compulsive disorders. A hoarding disorder is an obsession with the accumulation of belongings that have little or no value. As a general rule, hoarding is very hard to treat, and we've tried different medications with hoarders, different types of therapy with hoarders, and this is an area where there's a lot of research going on because at this time there are not a lot of really good effective treatments for hoarding. How many people out of our national population suffer from anxiety disorders? We think as many as 18 to 20% of people in the United States suffer from anxiety disorders. This makes anxiety disorders the number one mental illness in the world and in America. More work days are lost because of anxiety disorders. Um, it is very, very common. So we think that approximately 40 million people in the United States suffer from this disorder. You will see this behavior in your patients no matter where you work. Generally, it becomes a problem for the patient prior to the age of 21. We think that 5% of Americans are hoarders, just to let you know. Now, people that have anxiety disorders often have comorbidity with other psychiatric diseases. We think that other psychiatric disorders coexist with about 90% of people that have anxiety disorder, particularly if they're diagnosed with generalized anxiety or panic disorder. We know that there are some biological factors that predispose some individuals to pathological anxiety. Anxiety and panic disorders cluster in families, and we believe that people with anxiety disorders have low levels of the neurotransmitter GABA, G-A-B-A. We also have found in the last 10 years that there's a relationship between strep infection as a child and the development of anxiety disorders. So that's a very interesting area of research that's currently ongoing. Why do people have anxiety problems? There are a lot of theories. Freud said that unconscious childhood conflicts are the basis for future symptoms of anxiety disorder. Freud believed that by repressing threatening ideas and emotions through the use of defense mechanisms, we bury ideas that are threatening to us, and this leads to the development of anxiety. Another researcher, Harry Stack Sullivan, says that emotional distress during our very early developmental years that resulted in our needs not being met, or either growing up in an environment of parental disapproval, causes the development of anxiety disorders. Now, for those of you that are parents, you probably are going to agree with one thing that Harry Stack Sullivan says, and that is that anxiety is contagious. Anxiety can be passed from the parent to the child to the infant. Infants feel the anxiety levels of their parents, and they may internalize this anxiety. We do believe that anxiety is a learned behavior, and we've learned this through research of the behavioral theorists. We also believe that, thanks to the cognitive theorists, that distorted thoughts and perceptions by the individual can be a foundation for the development of anxiety. So let me give you an example. The world is going to come to an end this coming weekend. That would cause, even though that's a distorted idea, that would cause the anxiety of many people to rise. Okay, lastly, cultural considerations. This is very interesting reading if you'd like to take a look at it. Anxiety is definitely experienced in different ways based on the culture that you're from. And there's an interesting little article in our book on page 291 about some Hispanic people from, I think, South America, who call anxiety an attack of the nerves, and they have very different symptoms than what we're used to in our society. So take a look at that, because that's interesting. Now, how are we going to apply the nursing process to anxiety? We're going to start with assessment and just go right through like we generally do. One of the things that we want to do is we want to assess for the symptoms of anxiety, We're going to talk about the need for self-assessment, and then we're going to follow the nursing process just like we normally do. People with anxiety do not usually require hospitalization. The only time they would be hospitalized would be if they were a threat to themselves or to other people. So when we're out in the community, we're seeing outpatients in the doctor's office or the clinic or whatever, it's good to use a scale to assess anxiety and anxiety-related symptoms. And I would like for you to look at page 292, and we'll do that in class on Monday. We'll practice using this assessment skill and how to assess a patient for anxiety disorders. There are some guidelines on page 291, anxiety and obsessive-compulsive disorder assessment guidelines that you'll find helpful. You're going to run into patients with anxiety and obsessive-compulsive disorders no matter where you work, and so the more you know about this, the better prepared you're going to be to deal with them. A nursing diagnosis that's often used for this area of mental illness is ineffective coping or chronic low self-esteem. One of the things that's important when we are planning our interventions is to include the patient in developing the plan. And we all know that if we do that, they're going to be more likely to cooperate, and we're going to end up with a greater potential for success. Okay, before you start planning your interventions, you have to understand what is their level of anxiety, because the interventions differ tremendously based on their level of anxiety. If they have a mild to moderate level, they can problem solve, but concentration has decreased, so our interventions for this patient need to result in decreasing the patient's anxiety level, providing a calm presence, discussing coping mechanisms, and being willing to be a listening ear. Severe and panic levels of anxiety leave the patient unable to problem solve, to concentrate, or even perceive reality. Nurses need to provide a safe environment for the patient because this person may be a threat to themselves and other people. And you want to make sure that the physical needs of this patient are met. Let me give you an example. If you have a person who's in a state of panic and they're just running back and forth, eventually they are going to become exhausted and dehydrated. So you have to think about this and contain them if necessary. Also, another intervention that would help is to remove them if they're in a chaotic environment, like let's say after a school shooting, you might need to move them to a quiet room to help them calm down and regain their self-control. So reducing stimulation is important. Sometimes if the person is so agitated that they cannot calm down, allowing them space to use large motor muscles helps to dissipate tension, and so that might be in the person's best interest. You just have to use the understanding of the disorder in planning the interventions that you plan for the person. And let me give you an example. Let's suppose you have a person who's totally lost it and they're just running everywhere. Well, you might leave them alone for 20 minutes so that they could get some energy out, and then you might move them to a more contained, quiet environment. You would never let that person just run around until they exhaust themselves. Let's take the patient, let us say, in a hospital room who's become extremely agitated and anxious. They're clenching their fists, they're pacing back and forth, then back away from that person. Allow them room and space to use their big muscles and to get as much tension out as they can. Let's say leave them alone for 20 or 30 minutes. Let them naturally calm down. Don't try to back them in the corner. Don't try to restrain them. Let nature take its course. Okay, so what's the best way to verbally communicate with a person with anxiety? Let's take a look at page 295. I think we'll probably talk about this some on Monday, so you guys can practice this, and we'll also learn ways on Monday to help them to perform their activities of daily living. Okay, let's go back to our case study. What would be some appropriate interventions for the parent whose child is missing and is panicking? You might want to maintain a calm manner. You could just remain with the parent. You might decrease stimulus if possible, like you could assure her that people are looking for her child and we're just going to step in this office here so you can sit down. You could use clear, simple statements and repetition. You could use a low-pitched voice and speak slowly and understand that you might have to repeat what you're saying multiple times. I'm with you. I'm going to stay with you. People are looking for your child. We've alerted the police. The security guards are looking for your child. I'm here with you. People are looking for your child. You may have to do that. Acknowledge their distress and just listen when they talk. Now we're going to cover the pharmacological interventions for anxiety. These classes of drugs you have already had, but we're just going to review them. We do use antidepressants to treat people with anxiety. We like to start treating anxiety with the first drug as an SSRI. So our first line intervention is going to be an SSRI, a selective serotonin reuptake inhibitor, and some common drugs that we use in this class are Zoloft and Paxil. What does this do for the person with anxiety? It provides a calming effect, and if they also have a depressive disorder going on at the same time, it addresses that issue too. Another type of drug that we use is the selective norepinephrine reuptake inhibitor, and some common drugs in this class are Effexor and Cymbalta. Now, I know you see the MAOIs up on the slide, but I want to remind you that these drugs are very difficult for the patient to use safely. So this is the drug of last resort. We are only going to use an MAOI because nothing else works. So that's our last ditch. And what are the, so we call that treatment-resistant conditions. And I want to remind you that MAOIs are very dangerous because they're prone to cause a hypertensive crisis. The patient has to be on very restricted food lists because they have to avoid the substance triamine. And we would never give an MAOI to a patient that was not trustworthy. So the patient with substance abuse disorders, they are not a candidate. Okay, now please review the drugs that are from the antidepressant class to treat anxiety, and they're in table 1513 on page 297. anti-anxiety drugs also include the benzodiazepines, and these drugs are controlled substances. Why do we use them? Because they act quickly and they're good for short-term treatment. They are drugs that cause dependence, so they're not a long-term treatment choice for anybody, or they should not be. Now, they do cause certain side effects that make them dangerous to use, so you must know as the nurse to watch for sedation, ataxia, and decreased cognitive function. It would not be safe to use these drugs and then to try and drive or use any kind of dangerous machinery. And they're also contraindicated. They can't be used during pregnancy, breastfeeding, and they're definitely not for the substance abuse patient. Also, you want to teach your patients not to mix these drugs with alcohol or they might die. And if they mix them with caffeine, like for the different things we drink that have caffeine, the caffeine can decrease the effectiveness of the drug. If we use them for more than 2 or 3 months, the patient will probably go through withdrawal and we'll have to slowly step them down. These should be taken with meals, and we have to check for drug interactions because they interact with a lot of stuff. Now, one exception to the benzodiazepines is Buspar, B-U-S-P-A-R. It is an anti-anxiety drug that doesn't cause dependence, but the drawback with Buspar is it takes 2 to 4 weeks to become effective. If you'd like to review the benzodiazepines, please look at box 15-2, and that goes over your anti-anxiety medication teaching, and that would be good to know. We may also use beta blockers, antihistamines, and anticonvulsants. We go to these drugs if our SSRIs don't work. And then there is a very interesting drug, and that is called D-cycloserine. D-cycloserine, believe it or not, is an antibiotic that was developed to treat TB, but it affects the part of the brain that's associated with anxiety, which is your amygdala, and it helps the patient to unlearn fear responses. So sometimes it's very effective in the treatment of the different anxiety disorders. Some patients want to avoid doctors, and so they try to self-treat with herbal therapy and dietary substances. And one of the most popular one for the treatment of anxiety is kava. So you might want to ask your patient if they're taking this particular substance. It does have a significant impact on the liver, and it can cause inhibited liver function, which makes it hard for the patient to metabolize the other drugs that they're on. It's not FDA monitored or approved. It's a herbal therapy that's not controlled by the FDA, so just be aware of that. Now, what are some of the other interventions we are going to try for all these people with these different anxiety disorders? We may try cognitive therapy. Cognitive therapy is based on the belief that errors in thinking result in negative beliefs about yourself and others, and these negative beliefs can increase your anxiety. So what we do with the patient is called cognitive restructuring. We try to remove those errors in thinking. So we start by trying to help them identify their negative beliefs and then identify the basis for their negative beliefs. We try to help them reevaluate the situation, And we also try to help them to replace negative self-talk with more supportive ideas. Behavioral therapy is also helpful for this population. There's lots of things that they can learn. They may be learning relaxation training. They may be learning healthier ways to get their needs met. What is modeling? Modeling is when you model, as the healthcare provider, appropriate behavior. So, as an example, you might get into the elevator with a claustrophobic patient, and you would model appropriate behavior in an elevator. Flooding, okay, let's talk about systematic desensitization. Let's suppose we have a patient that's so afraid of a particular object that they have a panic attack when they are near that object. So systematic desensitization is gradually introducing the feared object over a period of a very long time. Flooding is the opposite of systematic desensitization. This is a treatment where you expose the patient to a large amount of the undesirable stimulus in an effort to extinguish the anxiety response. Also, response prevention is when the patient, this is used for obsessive-compulsive patients, you refuse to allow the patient to perform the compulsive ritual. And that's a special kind of therapy. That's not something we would do in the therapeutic milieu. It's just during the therapy session that they would do this. Now, some examples of response prevention you've probably already seen and didn't know what the patient was doing, but you may notice that some patients have like a rubber band around their wrist, and when they're trying to stop a compulsive behavior, if the idea of the compulsion comes in their mind, they'll snap that rubber band, and that represents a break in the negative thought, and then they make themselves put in a more positive thought. And let's use, for example, did I lock the doors? The obsessive-compulsive patients at work, and they get that thought, did I lock the doors? And that tremendous need to leave their work and go home and see if the door's locked. So they snap the band, and then they replace it with a healthier thought. I know my doors are locked. I need to do my work. So that's an example. And then cognitive behavioral therapy is just a combination of the cognitive therapy, where we're dealing with helping people change their thought process, with behavioral therapy, where we're helping them change their behavior. I hope you've enjoyed this lecture. Anxiety disorders are very interesting. We'll talk more about them on Monday, and good luck on your ATI exam.